So that's basically where we left off on Tuesday. And when we talk about biomarkers, these are substances, sometimes enzymes, sometimes broken down products. Because remember, you have a heart attack, the heart muscle dies, and some things are going to leak into the bloodstream, and you can measure those things. And troponin is uh, is one of the substance that's in the muscle, the heart muscle. So when the heart muscle dies, you leak troponin in the circulation, and you can measure the troponin level. Um, Also, the BNP, which we've been talking about, it's not in the, it's manufactured and released in response to increased pressure, usually in the atria, the atria, usually left atrium. So if there's increased pressure and stretch in the left atrium, usually caused by heart failure, then the BNP is released in the circulation. You can measure that. So an elevated BNP will tell you that the patient probably have is having some type of heart failure, increased atrial pressures. There are other things that can cause elevation in the BNP. So it is, it is not pathognomonic of a heart failure. There are other things that can cause elevation. But it's good for prognostication in terms of telling you how well these patients are going to do, because if the patient is in heart failure and have a non-ST segment elevation acute coronary syndrome, they're going to do worse. Okay, they're going to do poorly. Now, we did all the stuff, and we're going to discharge a patient from the emergency department or the chest pain unit. So therefore, we're going to send the patient to the ward. We're going to send the patient to we're talking about in hospital care. How do you care for these patients in the hospital? Okay, we went over what we do in the ED already. So if the patient does not have any objective evidence of myocardial ischemia, that is, the EKG looks okay, and you did multiple ECGs and they're not changing, and the troponin is normal, then you can put them in the hospital, and then you're going to run serial ECGs. Remember, this is an evolutionary process. Sometimes after a few hours, then the ECGs start to change. So you have to do serial ECGs and serial troponins, because when the heart muscle dies, and what will happen is, when you have reduced blood flow to the heart muscle, patients will develop chest pain, and then that blood vessel may completely occlude and give you infarction, that is heart muscle dying, and then releasing the troponin in the circulation. If you remember the pathophysiology of your ischemia, you have the plaque, you have the unstable plaque with the thin cap and the high lipid content. It bursts. So when the plaque ruptures and the blood clots on top of that, it's a gradual process. You're not going to get complete occlusion right away. So it may take an hour before the heart muscle, you know, shows signs of death, and then over the next hour, it releases the enzymes in the circulation. So you have to do your troponin every 3 to 6 hours. And different institution may have, but the range is 3 to 6 hours. Your institution may decide to do it every 4 hours. But the important point is that serial ECG and cardiac enzymes, once a patient hit is in patient. Now, if the troponins are negative, so the patient comes in with classic chest pain suggestive of acute coronary syndrome, whenever and the cardiac troponin is negative, and the ECG is not very suggestive. It's reasonable to do a stress ECG in the hospital, or you can do a stress ECG, or you can do what we call a myocardial perfusion scan or a stress echo. It depends on, if the ECG is completely normal, no STT changes, you can just do an exercise treadmill test. However, if the ECG is abnormal, you have STT changes, you may want to do your myocardial perfusion imaging. It's the nuclear study, or you can do a stress echo. You don't necessarily have to do that. If the patient is not unstable and chest pain, went away, you can do your stress test within 72 hours after the patient is discharged. So within 72 hours after the patient is discharged. So if the troponin again is negative, normal, didn't increase, and the patient has no history of coronary artery disease, you can do a CT angio to look at the coronaries. So CT angiography is a special CAT scan, or you can do, a nuclear study. So those are options you have. And if you're going to send, if the patient is very low risk and you're going to send them to have tests on an outpatient, in the interim, you can give them aspirin and sublingual nitroglycerin and beta blockers until they do the tests. So patients already sent to the hospital. What are we going to do when the patient hit the hospital? So early hospital care, everything in green you have to do. If you don't do green, you're liable. Okay, so you can see class 1 indication. You have to give the patient oxygen. If they are having chest pain, you should give them nitrates, sublingual nitroglycerin, IV nitroglycerin. You have to, so where you say red, that's danger. If the patient took Viagra or Cialis or anything like that, you don't want to give them nitroglycerin, you will kill them. So anything in red you stay away from, okay? Again, green is good. So remember, this is in-hospital care, early hospital care. So class 1 again, the patient should be placed on a beta blockers, and it's important to know so all beta blockers are not created equal. So in the studies looking at ischemia, the beta blockers, mainly heart failure, the beta blockers that were shown to be beneficial is the metoprolol succinate, carvedilol, and bisoprolol. So these are the medications that you should give, not atenolol, not metoprolol tartrate. We gave metoprolol tartrate, but it was not shown to be beneficial, compared to these three. So beta blockers should be given unless there's contraindication to the beta blockers. Okay. If the patient is in shock, you want to stay away from the beta blocker. Again, anything in green is good. So the patient does not have heart failure, and you can't give beta blockers. You can give your non-dihydropyridine calcium channel blockers, and those are your diltiazem and verapamil. Okay, so if the patient cannot take beta blocker is first. If the patient is having heart failure, ejection fraction is low, you should not use your verapamil or your diltiazem, and don't use nifedipine. They have short-acting or immediate-release nifedipine. Don't use nifedipine, period, in these patients. Okay, just stay away from nifedipine. Cholesterol, you need to, when these patients comes in, because some of these patients have never been to the doctor before. You want to get a lipid profile. You want to see what their cholesterol breakdown is, but this has to be done within 24 hours. If you wait more than 24 hours, it's not going to be accurate because of the inflammatory process that's going on. So let's look at what we need to do in a little bit more detail. So the patient is now in the hospital. We get them up from the emergency department. So supplemental oxygen should be given if the saturation is less than 90%. So if the O2 saturation is greater than 90%, you don't really have to give oxygen. If the patient is in respiratory distress or there's any evidence of hypoxemia, you want to do that. They come in with chest pain, and if the chest pain is ongoing, you can give them sublingual nitroglycerin in a dose of 0.3 to 0.4 milligrams every 5 minutes, up to 3 doses. And then you're going to reassess them. If they continue to have chest pain, you want to use IV nitroglycerin, as long as it's not contraindicated. All right. And if especially if they're hypertensive, or if there's an heart failure. So blood pressure 220 over 110, and they haven't, you reach for it, because the intravenous nitroglycerin can lower the blood pressure gradually and take care of the chest, the ischemic chest pain as well. And then if they're in heart failure, due to LV systolic dysfunction, ejection fraction less than 40%, when you give intravenous nitroglycerin, it unloads the heart. It decreases venous return, so it will relieve congestion. And as we mentioned before, do not give nitrates if the patient is taking sildenafil, vardenafil, or tadalafil. So any, Cialis, Viagra, nothing, you have to wait more than 24 hours to give your nitroglycerin. If they continue to have chest pain, you can use morphine sulfate. You can use morphine sulfate to relieve the chest pain. What you don't want to do is use non-steroidal anti-inflammatory drugs, your Motrin, your naproxen. Do not use these medicines, because there are studies that show that they can increase the infarct size. If the patient is on any of these anti-inflammatory medicines, you need to stop it when they're in the hospitals, when in the hospital. And then the beta blockers that we talk about, it's one of the mainstay in terms of therapy for acute coronary syndrome. So if the patient comes in with acute coronary syndrome or non-STEMI and they're not on a beta blocker, that's malpractice. So, they should be on a beta blocker unless they're contraindication. And, contraindication, the PR interval greater than 0.24, if they're in second or third degree heart block, or if there's signs of shock. If the patient is going to go in cardiogenic shock, that is, if the systolic blood pressure is less than 100, they're cool and clammy. If they have bronchial asthma, they're wheezing, you want to stay away from beta blockers. But if that's not the situation, you have to give beta blockers. And as we mentioned before, the beta blockers that have been shown to be effective, that is metoprolol succinate, carvedilol, and bisoprolol. Okay, the other beta blockers they did not reduce mortality in heart failure patients. If the patient initially could not take beta blockers, you need to reevaluate them within 24 hours, because beta blockers have been shown to reduce mortality quite significantly in these patients. So you need, if you can get it on board, you need to get it on board, but don't force it though, because if the patient is going into shock and you give them beta blocker, it's going to increase the mortality. All right. If the patient have normal LV systolic function, you can continue with it. If the patient is going into shock, do not give them the beta blocker. You will kill them. So, patients who in active heart failure, systolic blood pressure less than 100, you want to stay away from beta blockers. So we talk about the calcium channel blockers. If they cannot take the beta blockers, then you can give your non-dihydropyridine calcium channel blockers, such as the verapamil and the diltiazem. Make sure that the ejection fraction is normal, though. If the ejection fraction is abnormal, you can't use these. Okay, you can't use them. And also, if the patient have second or third degree heart block, you can't use it. You can use, especially if the patient is cannot take beta blockers. You can use long-acting nitrates and some of the non-dihydropyridine calcium channel blockers. But try and get if you can't get the beta blockers, then you can be forced to use the calcium channel blocker. Don't pull for this medicine immediately when someone comes with acute coronary syndrome. If you give them beta blockers, you give them nitrate, and they're still having ischemic events, then you can give the non-dihydropyridine calcium channel blockers. But make sure that there's no contraindication to the use of these medicines. If patient is having coronary spasm, you're familiar with the patient and you know that they have coronary spasm, then long-acting calcium channel blockers and nitrates may be indicated in those patients. Again, do not use nifedipine. It says immediate release. Just don't use nifedipine, because a lot of studies have shown increased mortality with nifedipine. Cholesterol, the major risk factors for someone having an acute coronary syndrome is hypertension, diabetes mellitus, cigarette smoking, cholesterol, dyslipidemia or high cholesterol, and a family history. So you need to know what the cholesterol level is. You want to look at the cholesterol level within 24 hours. If you wait longer than that, because of the inflammatory process that's going on, the level you get is going to be unreliable. So you want to get it done within 24 hours. Patients who are having acute coronary syndrome should be treated with high intensity statins. Statin is one of the major players in cholesterol management. And those of you who didn't I gave a lecture on the use of statin, among other things, in patients with coronary artery disease, and we divide it into moderate or high intensity statin. If the patient has a high risk, if the patient have a risk which is greater than 10%, then they should be on high statin therapy. And acute coronary syndrome patients are at high risk for coronary artery disease. They may have active coronary artery disease. So these patients should be treated with high intensity statin. And when we talk about high intensity statin, atorvastatin 80 milligrams, rosuvastatin 40. So make sure they're on those medicines. The renin-angiotensin-aldosterone system, those medicines, the ACE, the HARB, and the aldactone. So ACE inhibitors should be started and continued indefinitely in all patients if the ejection fraction is less than 40%. So, patient is now in the hospital and you do your echo and they have acute coronary syndrome. If the ejection fraction is less than 40%, they should be on an ACE inhibitor. If they're intolerant to ACE, or the ACE is contraindicated, then you can use HARB. So the angiotensin receptor blockers, um, if they cannot take the ACE inhibitors, um, and then if the ejection fraction is less than 40% and they're on an ACE inhibitor and a beta blockers, you can start aldosterone a blockade, especially if after an acute infarct, after the patient have a heart attack. So your spironolactone, your aldactone. Make sure, however, that the patient renal function is okay. That is, in male, make sure the creatinine is less than 2.5. In female, make sure the creatinine is less than 2. Make sure the potassium is less than 5, because your aldosterone, your spironolactone, your aldactone can increase the potassium and cause problems. So make sure that's not the case. We talk about the angiotensin, the HARB, angiotensin receptor blockers. So you always have to remember the medicines that you can use and make sure there's no contraindication to the use of these medicines. You know, in the hospitals over here in the United States, they constantly reviewing your chart. They constantly reviewing your chart, because if you fall out, you're going to get a letter, and sometimes they'll send you, in the letter there will be, you know, compared to other physicians, how you fare in terms of, are you using ACE inhibitor and HARB when it's indicated? If you're 50% and other physicians are 90%, because they're going to compare you to physicians in the area. So you'll get these type of reports, and it doesn't look good. So you need to know what medicines are indicated, and then is it contraindicated in this patient? And if it's not, then a patient should get medicine. So patients still in the hospital, we give them the oxygen if it's needed. We give them the beta blocker. We give them the ACE inhibitor, the aldactone, the nitroglycerin. We do all of that. We're doing our serial EKGs and our serial troponin. So remember, there are two approaches. We talk about the ischemic approach. That is, we just give them the best medicine. These are stable patients who not having a lot of chest pain. The chest pain resolved. The troponin probably didn't go too high, and they're very stable. And patient is also a part of the treatment team. And if they decide that they just want medicine, so ischemic guided approach, then we have the invasive guided approach. That is, if the patient is high risk, remember Timmy and Grace. So if the Timmy and Grace show that these are relative high risk patients, then we want to take them to the cath lab, not urgently, because studies have shown that if we take them too soon to the cath lab, we have increased mortality in these patients. These patients don't do too well. So the sicker patients, we take to the cath lab, okay? But we should put them on antiplatelets and anticoagulants. So one of the mainstay in treating these patients is antiplatelet drugs and anticoagulant medicine that prevent clotting. Because remember the pathophysiology: plaques, unstable plaque, plaque ruptures, blood clot. Most of the clotting on top of the plaque is due to platelet clumping. So antiplatelet therapy is very important in the management. Green is always good. So the P2Y12 inhibitors, and these are potent platelet inhibitors. We have clopidogrel, prasugrel, and ticagrelor. So, if the patient have an acute coronary syndrome, and we treat them with a stent, PCI, percutaneous coronary intervention. That is, essentially what that means is a stent and probably angioplasty to a lesser extent. So they should be on these medicines for at least 12 months. Okay, so we let's just stick to the green. There are other things that we can do, but when these patient comes in, and when we're going to take them to the cath lab, we usually load them with these medicines. So if we determine that the patient is going to go to the cath lab, not urgently, but probably after 24, 48 hours, because we look at the TIMI score and the patient, is a high risk. So we load them with these P2Y12, that is the clopidogrel, prasugrel, ticagrelor. Okay, so these, and then in addition to this, we're going to give them aspirin. So you'll see in the literature we talk about dual antiplatelet therapy, DAP therapy, DAPT, dual antiplatelet therapy, because these patients should be on an aspirin and one of these medicines, clopidogrel, prasugrel, or ticagrelor. So those are the antiplatelets. Now, we also have clotting. So remember, blood clot is a complex thing. It may be due to platelet clumping together, or maybe due to coagulation factors which cause the clotting. So we have to deal with the coagulation part of it now. So we can use enoxaparin or Lovenox. So a lot of institution is using Lovenox, and you dose them at 1 milligram per kilogram sub Q12, so twice per day. Okay, so a 70 kilogram man or woman should get 70 milligram Q12 subcutaneously, not intravenously. You can give them a loading dose initially. Then there are some other stuff only people doing exams, physicians need to know that. Bivalirudin, if you're going to use bivalirudin, you only use it if the patient is going to have a stent. Okay, so bivalirudin is only used in the cath lab. You don't use it outside. And then fondaparinux, which is an anticoagulant, fondaparinux. If you were using fondaparinux and you take the patient to the cath lab, you have to switch to something else because this is no good in the cath lab. So people doing exam need to, physicians, that is. And then, of course, you can use heparin. Good old heparin is still used, So in addition to the antiplatelets, you're going to use anticoagulants. Now, people doing exams, physicians, that is, this red means something. Patients with non-STEMI should never get thrombolytics. Thrombolytics, these are clot-busting medicines. These are medication that will dissolve clots. Only STEMI patients should receive this medicine. Only STEMI patients, ST cement elevation, heart attack patients should receive those medications, okay? And so remember, we talk about the DAP therapy. So you're going to give the aspirin, and the dose when the patient, first get to the hospital, you're going to give them 162 or 325 milligrams of aspirin, not more than this. And then after that, that's day one. After that, they get about 81 milligrams. So we tend to shy away from the 325, 81 milligram per day. And for acute coronary syndrome patients, we treat them indefinitely with that. So again, if we're going to take the patient to the cath lab, we load them with the clopidogrel and the ticagrelor and the prasugrel. So we give them a loading dose. We don't, if the patient is 75 years of age or older, we don't load them. Don't load them. So, doctors who treat these patients, remember, it's not uncommon for me to go in doing a consult and the 80-year-old patient was given a loading dose of 600 milligrams of clopidogrel. That's inappropriate. 75 milligrams. You don't load patients over 75. So again, clopidogrel, ticagrelor, for at least 12 months. There are updates on these. You can reduce it to 6 months. We'll do the updates. But if you're going to load with clopidogrel, 300 to 600 milligrams, and then 75 milligrams thereafter. For the ticagrelor, which is Brilinta, clopidogrel is Plavix, and ticagrelor is Brilinta. You load it 180 milligram and then 90 milligram twice daily. Okay. Ticagrelor is probably a better drug. So in most of the head-to-head studies, ticagrelor won. So if you can use ticagrelor, use it. So again, the DAP therapy, dual antiplatelet therapy, that is aspirin plus one of the P2Y12. We had a million years ago, we had glycoprotein 2B3A. This is a very potent antiplatelet, intravenous. It's still used very, very rarely. Only physicians need to know about this. Okay, so let's all right, what's we have here? So if the patient have a stent in place, the patient have to be on DAP therapy. Lest the stent can thrombose. We talk about the anticoagulant enoxaparin, 1 milligram per kilogram sub-Q every 12 hours. This is Lovenox. This prevent clotting. Okay, so most institutions will probably use this. Fondaparinux is not used a lot. Bivalirudin is only in the cath lab, so physicians need to know that. Only if you're going to do angiography or stent, you would use bivalirudin. Fondaparinux, if the patient is going for a stent, you have to use a different anticoagulant. This doesn't work in the cath lab. All right. And again, good old heparin. Heparin is good. And then we talk about if the patient have a non-STEMI, you can't use fibrinolytic therapy. So this is for doctors, really. The clot busting medicines do not work in your non-STEMI patients. There's increased mortality in that group. It does work well with your STEMI patients. The only problem is, well, not a problem. Stenting provide reduce mortality and morbidity as compared to your thrombolytics. That is why patient comes in with a STEMI, they're going to go to the cath lab and they're going to get a stent because those patients tend to do much better than if we use thrombolytics or fibrinolytic medicine. Okay, so let's stop here, and I think we have one more session to complete. This section, but non-STEMI is very common, and as we had shown before, majority of your heart attack is non-STEMI, so you should have an idea how to approach those patients. So right, so on next week Tuesday we will finish up. All right.